Welcome back, class. We're going to talk in this second segment or the second part of our module. We're going to talk about the advantages of ethical guidelines. And I think the first one that, at least right off the bat for me, that kind of jumps out is it guides healthcare professionals. It guides their decision-making process. It combines, the moral compass. It combines the ethical policies and practices to ensure that healthcare professionals, whether it's the doc in the box, whether it's the telemedicine dude, whether it's the orthopedic surgeon, whether it's the hospital, the ambulatory surgery center, that they are providing access to high quality, cost effective healthcare goods and services. Because at the end of the day, we as individuals, we as consumers should be concerned about our health status. We're all born with a certain level of health status. That health status, it's either up to us individually or, when we're younger, via our parents to ensure that we are following all of the guidelines and that our healthcare providers, based on the ethical standards, are heading us in the direction and providing protocols to ensure that our health status builds over time. And then as we get older, health status, just like, your automobile or, any type of machinery, it starts to deteriorate. I mean, it's just the fact of growing old. Health status starts to deteriorate, starts to depreciate. And that's one thing that your healthcare provider should be focused on. They shouldn't be focused on, how many dollars they're going to make that day or how many patients they can see that day, or, they're going to make enough money to buy, their new sailboat or buy that new vacation home in Florida or whatever they're thinking about financially. You want our healthcare providers to be focused on how to maximize your health status, my health status, anybody that walks into that office to see them. So to me, again, healthcare, medical, clinical ethics, whichever one you want to pick, that is the ultimate goal from my perspective. You want to ensure that patients are treated with dignity and respect. I've had a lot of providers that arrogant, condescending, make comments that should never be made in a healthcare office. And that's not the type, you can call it bedside manner, you can call it professionalism, I don't care what you call it. But you want patients to be treated with dignity and respect. And that's what ethical guidelines should provide with these healthcare providers. You also want the guidelines to ensure that the patient, as they walk into that doctor's office, has the trust and the confidence that they can, hate to hear people talk about bare their soul, but they can tell their doctor within, confidentiality, at least within those parameters, things that they might not tell other people. And they want to be you want the patient to feel that they can be forthcoming. And, if you want them to feel comfortable enough with their provider that if they're having 5 or 6 drinks every night, you want them to be comfortable enough to say, yeah, I probably drink too much. You don't want them to go in, concerned about, how much information to share and say, oh, no, I don't ever drink. Because that's not going to do anybody any good. You want to ensure that decisions are fair and just. And when I say fair and just, you want those decisions to be consistent over age, sex, social status. You want a fair playing field, and you want to have the ability as a patient to be able to select the provider that you think as a patient is going to provide you the highest probability of a positive outcome from that healthcare visit, whatever the cause that's driving a healthcare visit. I think not too long ago, it was in Southern California. There are two main hospital systems in Southern California. And when I'm talking Southern California, I'm talking about San Diego area. You've got Scripps, you've got Sharp. And you've got UCSD, which is a teaching research hospital, and you've got Mercy Healthcare, which is, I think, with Catholic Healthcare West, and they all serve their purpose. But again, Scripps and Sharp are the two big 800-pound gorillas in the San Diego market. And I can't remember. It seemed like one of them had decided, or maybe both of them had decided, they weren't going to take Medicare Advantage anymore. Couldn't make enough money. Financial decision. We can't make enough money. We're tired of dealing with the old folks, and we're just, Medicare Advantage. It's just not a financially viable product line for us, or a line of business, and we're just not going to take it anymore. How does that make you feel if you're a Medicare eligible individual living in Southern California? There, we're talking about age. You have certain providers that hate dealing with women. I mean, it's just it shouldn't be that way, but there are biases among providers, and so that's when we talk about decisions are fair and just. You want everybody to have equal opportunity to select the provider that they think is going to provide them the greatest possible outcome. Advantages of ethical guidelines, we hope mitigates the principal agent dilemma that I talked to in the first segment. We don't want to end up in a situation where we're faced with SID, or supplier induced demand. You don't want to go into this principal agent situation where and it goes back to, we're talking about trust and confidence. You don't want, as a patient, to feel like you have to hide information from the provider, but you do want to have a sense that the provider that you're going to see has been trained, that hopefully they know more than you do. Even though, as I said in the past, I've run into a lot of doctors that I don't think know nearly as much about healthcare as I do. And man, I'm just an economist. I'm an economist. I managed medical informatics shops. I've built provider networks. I've been involved payment integrity. But sometimes some of these yahoos, I don't know where they went to medical school. Especially in the emergency room, urgent care, teledocs. I mean, if I'm selecting a primary care doc, usually I can get out on the internet and I can determine, age, sex, where they went to undergraduate school, where they went to medical school, where they work, did they do a residency, did they do an internship? I can make my decision based on that information, but there are a lot of situations that I don't know. You go in and you start talking to a provider, and you just don't get a good feeling. And at that point, if you go in and talk to a provider and then you think this yahoo just is completely out in left field somewhere, at that point, and I've done it in the past, just say, doc, this is not working. You're not going to get me from point A to point B in a positive result, and I'll just find somebody else. And it upsets them, and they get bent out of shape. But as a patient, that's my prerogative. I'm a patient. I'm paying for that healthcare good and service, and I should feel like they have the opportunity to go seek a second opinion, to go find just another provider, just in general. We also hope it mitigates asymmetric information, especially when it comes to financial quality information, because most individuals, if you ask them what was the quality, what did they think was the quality of their most recent office visit, Most people can't tell you. I mean, quality under the best of circumstances in a healthcare environment is extremely difficult to measure. The quality, you can have 5 different providers, and we'll just pick on internal medicine. You got 5 different internal medicine providers. I could go see each one of those 5, and I might have a reasonable idea of what the quality of each of those office visits are. Majority of the people that, especially if you've never worked in healthcare, it's going to be extremely difficult for you to go in and decide or discern which was the highest quality provider, which was the highest quality, I guess, the result of that office visit. And secondarily to that is the financial information. I can stand on a street corner and ask the first 100 people I see, when you go to the doctor's office, how much does it cost? And they're going to tell me their copay, or they may tell me their coinsurance, or they may tell me their deductible. Most individuals don't understand the pricing or the financial mechanism of the provision of healthcare goods and services. So you're hoping these ethical guidelines start to, at some point, mitigate some of these issues that we're facing on a daily basis. When it comes to ethical guidelines, and this one goes back to, remember the first segment I talked about health plans and I talked about patients, but when it comes to benefit plan and design, that's your health plan. Your health plan is going to design a benefit that's going to try to accomplish 2 things. One, a benefit plan that's going to be conducive, or a benefit plan is going to be attractive to employer groups. It's going to help the sales team sell those health plan benefit plans to the employer groups and drive membership to that health plan. And 2, a benefit plan that's going to ensure that the health plan makes money. Health plans, and again, next we'll get a little more detail in the next module. But health plans, they're just like providers. They're in a business to make money. And I had until the stint that I spent in Buffalo with Blue Cross Blue Shield, I had always worked for for-profit health plans. I'd worked for Aetna, I'd worked for Healthcare, who's now Centene. Health Net, who's now Centene. I'd worked for United. So I'd worked for 3 for-profit health plans. They were equity-based. They had stockholders, and they expected earnings per share, and they expected that those in control, of those in senior management, were going to ensure that we were going to make as much profit as possible. I go to Buffalo, it's a not-for-profit. And I can remember the first meeting with my group of managers that were going to report to me. It was like, we were talking about financial goals. I got there like in September, and I'd been there about a couple of weeks, and we were starting to work on the financial goals for next year. I was looking at the financial goals. I said, well, we need to increase these financial goals, and we need to do a better job. And it was like I was asking for their firstborn. It was like, oh my God, we're a not-for-profit. We don't have to make money. And I'm looking at it and saying, what are you talking about? You may be a not-for-profit, but that's a tax classification. You've got, the health plan's got to make money. They can't stay in business. It's just, again, go back to the 3 pillars. 3 pillars are one of the main 3 pillars. You can talk about, decisions at the margin and opportunity cost, but just like on the patient with the health plan or with the provider, either one, it's that self-interest. It's that optimization. It's, can we maximize revenues at the same time minimize costs? Because you maximize revenues and minimize costs, you're going to drive profits. And any entity that, they're in business for one reason and one reason only. And I'm not just talking about healthcare. Entities in general from an economic perspective, they're in the business for one reason and one reason only, and that's to make a profit. I don't care what anybody tells you, they're there to make a profit. And that's where ethics come in on a benefit design from a health plan's perspective, is you want a benefit plan or a benefit design that you can sell to an employer group that's going to mitigate or minimize the deterioration in the health status of that employer group's employees. And that's what you're focused on when you're trying, or should be focused on from an ethical perspective when you're trying to design that benefit plan. Ethical guidelines also impact member-centric or member decisions. You want again healthcare professionals to be focused or functioning in the best interest of the patients. You want the patient to have as much information as possible so that they can make informed member decisions. I go into my doctor's office and we're sitting down and we're talking about, say I'm talking about my cholesterol. I don't know, pick something. Talking about something that you need to talk to your doctor about. And I want a doctor that's going to sit down and say, okay, here's the problem. You've got high cholesterol, or you've got back pain, or you've got knee pain. Let's just use knee pain. That's a good one. I don't want somebody to come in and say, yeah, your knee's bothering you. We're going to have to do a complete knee. We're going to have to do a complete knee replacement. And, whether you like it or not, that's what I've decided. That's not what I want from a provider. I want the provider to come in to me and say, you've got some probably issues with your knee. We're going to get, X-ray, CAT scan, MRI. We're going to get some kind of radiology to take a look at this. And when we get the results back, then the two of us are going to sit down and we're going to talk about the options. Said, I can give you a kind of ballpark. One option is, we use physical therapy and we use, get you some workout in the gym to hopefully that relieves it. We can do a scope on your knee to see if that helps. We can do, last thing we want to do is, an invasive complete knee replacement. So, and, here's all these options and here's the probability of success. And let me, as the patient, make that decision. I should be driving. I should be driving this decision process. You should be driving the decision process. The doctor or your healthcare professional's responsibility is to be functioning in your best interest, providing you all of the information possible so that you as a patient can make an informed decision. Ethical guidelines definitely should be impacting reimbursement strategies and rationing of healthcare services. When a health plan and a provider sit down to determine how much the health plan is going to pay for those provider services, that's in the negotiation process of a healthcare contract. Provider, individual doc, medical group, IPA, hospital, doesn't matter. Healthcare provider and the health plans get together, they negotiate the contracts. They want, you want ultimately to negotiate a rate that the health plan can sell to a employer group that is cost effective, high quality. You also want a rate that's not going to drive the provider out of business. You want the provider to be profitable. You want the health plan to be profitable. You want the member or the patient to have access to high quality, cost effective healthcare. And so that's why it is so important when it goes to this reimbursement strategy and contract negotiations that providers and health plans work together. And they don't. Very contentious. Some of the most stressful meetings I've ever had in my career in healthcare have been at the negotiating table trying to hammer out a contract that I know is not going to take advantage of the employer groups going to sell it to, or the patients or the employees that fall under those employer groups. ethical guidelines, especially on public policy. And public policy, 9 times out of 10, is just going to impact and it's going to be a drain on healthcare resources. I'm not sure I've ever seen a public policy decision or a public policy driven program that has ever accomplished what it was supposed to or what it was set out to do. Again, public policy works off normative statements. This is how it should be. This is how it ought to be. Public policy sometimes doesn't incorporate reality into their decision-making processes. And lastly, on ethical guidelines, it is data security. It is the utilization of a wealth of information in this patient, provider, principal agent issue. A lot of information is changing, exchanging hands. Also between the provider and the health plan. A lot of information is changing hands because the patient and the provider exchange information, develop a treatment protocol. Provider turns around and they have to fill out either a CMS 1500, which is your medical claim form, or a UB04, which is your hospital claim form, depending on what type of healthcare provider you've gone to see. And they have to submit that to the health plan or they don't get paid. And so information that has been gleaned from the patient and the provider's made some decisions, and all of that information goes into one of those claim forms. That's how you get paid. Tremendous amount of information flowing through in the vapor. So ethical protocols and standards have to be in place to ensure that you have data security, especially in that electronic processing of the claim. And with that, I think I'm going to stop for a few minutes. And when we come back, we're going to talk about the historical driver of healthcare ethics, because it actually originated, let's say, kind of in the bioethics field. And we'll talk about that when we get back. Thank you.